Okay, thanks for joining everyone. So the Digital Health Seminar Series is run by Mikkel, Matt, Emily, Sarah, me, and Emma. We have it every 2 weeks on Tuesdays from between 2 to 3 p.m. And right now we're having different rooms, but hopefully by next time it should be more stable. Okay, so just some housekeeping. If in person, register attendance in the tablet. The webinar will be recorded and made available online after. Online attendees, please stay muted during the presentation, and there'll be extra time for Q&A at the end of the talk. For online attendees, use the Q&A functionality, the chat, or put your hand up or ask a question. Yeah. And just introduction to our speaker. Our speaker is Antonia Tzemanaki. Sorry if I butcher your name, Antonia. At the University of Bristol. Her talks on dexterous manipulation and teleoperation in healthcare with the end user in mind. And just a bit about her, she is senior lecturer in robotics at the University of Bristol. She holds a PhD in medical robotics from UE, Bristol, and the Bristol Robotics Lab. She was shortlisted amongst 50 women in robotics you need to know about in 2021 and is on the board of directors of the Worldwide Network of Women in Robotics. Her research interests are human and robot hands, hand exoskeletons, robot kinematics, haptics, and wearable robotics. Some trivia, she also lectured me in robotics fundamentals a few years ago, but unrelated trivia. Her work is she focuses on application areas in surgery, preventive medicine, rehabilitation, physiotherapy, and dexterous teleoperation, as well as extreme environments such as nuclear and space industry. Now, if Antonia, if you can present now.
Where is it?
Okay,
yes,
I did share my slides there, yeah?
Yes.
Okay, thanks so much for the introduction, Arvid, and maybe you and I need to sit down at some point and tell me how good a lecturer was back then at the robotic fundamentals. I think you're laughing. Anyway, thanks everybody for joining, and I'm really sorry I can't be there today in person. I did plan on it, but unfortunately, I'm feeling a little bit under the weather yesterday and today with some fever, but it's just the regular reminder of COVID times, I guess, and how we need to set up everything to be a little bit more hybrid. So, I'm talking to you today about dexterity manipulation, but especially for healthcare. And my group has a really long name. It's called Dexterous. Sometimes I don't even remember the name of the group. Dexterous Manipulation and Wearable Robotics. It's called, and there's a few PhD students in it. I think the number is probably 9 at the moment, including the ones I'm first and second supervisor, and 2 postdoctoral researchers, 2 SRAs actually. So why dexterity? I've been obsessed with dexterity for many years now. I think it has to do something about the fact that without our hands in the current form that we are now, we probably wouldn't have gone a primeval ooze species. And this is something that a lot of scientists and philosophers and even science fiction writers have been talking about over the years. So I saw a few years ago these pictures of what we call homunculi, sort of an artificial human. And in these pictures, the biggest a part of the body is, the more of a function it has, the more of a part it plays in that function. So the left one is the motor and the right one is the sensory. So you can see, for example, for the sensory homunculus, the tongue is quite big. The lips are big because we use them to taste and feel and really have a lot of sensory, input there. But what, of course, interested me was that in both of those, motor and sensory homunculus, the hands are really big because we use our hands to interact with our everyday environment. We use our hands to learn, to manipulate, to teach ourselves, to do more than that, of course. We use them since we are babies to understand the world around us. We use them to create amazing things such as music, to cook, feel, play, perform surgeries, and also to be intimate and feel each other, because without that, obviously, we are not even full humans. So my group is called this, and we do varied things in our group, okay? So we focus on a very broad interpretation of dexterity, covering things such as tactile sensing and haptics. How do we feel and how do we interact in taking as much detailed information as we can from the world around us, but also then applying this then into different types of healthcare applications, such as diagnosis, treatment, physiotherapy, rehabilitation, and a little bit further that I'm not going to cover today, but teleoperation in surgery, but teleoperation also then in nuclear applications and space applications. And the reason I went into that domain is because I just found that it was pretty much the same as doing surgery. If you're doing teleoperation in surgery, you can do teleoperation anywhere. In a way, the principles are the same. The requirements are often the same, although surgery sometimes is a little bit more demanding. So these are some of the parts of the research that I'm not going to cover too much today. So for my PhD in medical robotics back in 2016, which finished then, I basically looked into surgery and I created this sort of multi-finger, high degree of freedom instrument that you see on the top left. And the idea was to teleoperate that with a hand-worn wearable device. So the surgeon would wear something on their hand and then directly operate the surgical instruments, try to go a little bit far away from the sort of chopstick of forceps and laparoscopic instruments that surgeons use even as we speak. I also worked quite a lot in creating different gloves and exoskeletons for the hand, some rigid, as the blue one that you see on the top, or something that's made out of leather, the black one on the top right, or something that's made out of the silicone. And the silicone one is actually ongoing work, because I've been looking into making something that is really cheap to manufacture, really quick to manufacture, not 3D printed, not 3D structure, but just one flat sort of sheet of silicone that you can put in the laser cutter and really cut in 5 minutes and then mold on someone's hand to make it as comfortable and as futuristic or pretty as you like. Another series of work that we're doing is making phantoms or medical simulants. So you can see in the middle one a model of lungs, pleural space, and rib cage, sort of simulated in different layers that we have out of silicone, out of different types of silicone, or even the bottom one here. Can you see my mouse, by the way? Hopefully you can. Yeah, okay, thanks, Mikhail. This at the bottom here, which might just look to you as crunched up balls of some discarded silicone, is actually a simulant of a bladder. And this was made by a prior CDT digital health student, Morgan, who worked on making models of bladders, but are also sensorized. So this work is still ongoing, of course. And then on the bottom left, this is work from Yael. She's working on sort of patient education and clinical education by making simulants of the pelvic floor musculature. But again, sensorized and actuated to try then to look into how we can give a better training, a better dexterity to physiotherapists when they examine for such conditions. Finally, the bottom right one here is relating to endonasal skull-base surgery. This is basically when the surgeons are entering your skull through your nose, up the nasal cavity, and they are using micro drills that are not really drilling vertically, but they have this burr, so they basically grind away on your on the bone inside your nose to try to get to the area just outside of the brain that might have a tumor, and they want to just remove that tumor. So this is an interesting project to get ongoing. This is a PhD work, probably a little less than a year left of it. And we're looking at the patterns of the forces when the drill causes, well, the burr is causing, to try then to use machine learning to create, to distinguish between the different patterns and then predict when you're going through the different layers and then stop before you go somewhere that is dangerous. So I'm going to move on to a big work that we're doing now for, I don't know, a bit now, probably 5 years or a bit more. and it's about robotics for surgical needle steering. So we have been looking at different applications. We started with biopsy of the prostate. Then we, at the same time, but a little bit later as well, we started working in brachytherapy, which is a treatment of prostate cancer using radiotherapy. And lately, we've been doing something in between those things, I guess, which is called spacer insertion, which is basically when you try to inject a barrier between the colon and the prostate, so that when you actually do brachytherapy, when you apply these radioactive seeds onto the prostate, they do not harm the healthy colon, so that they can improve the quality of life of a patient. So all of this sort of came one after the other. We did biopsy and we said, oh, some of the techniques that we're using there, maybe we can use in brachytherapy, and so on and so on. And then I was talking to Steve, who is a respiratory doctor from the medical school. He said, oh, but these techniques also can be used for sort of pleural aspiration, which is when you have infection in the pleural space outside your lungs. So I'll go through these and in more detail. So I'll start with the pleural effusion. So it's a buildup of fluid, usually fluid, sometimes buildup of air between the lung and the chest wall, roughly. There are many new cases per year in the UK, and that's on top of the existing already ongoing cases. This condition is linked to, of course, congestive heart failure, pneumonia, and cancer. So that is any type of cancer, right? So imagine being, having cancer and having all the problems you might have, but at the same time also developing this. And then basically that means that you have difficulty breathing, you're feeling a burden in your chest, and it can be something that should be treated as soon as possible, but there are really long lines of actually seeing a specialist. So the current paradigm to treat that is basically to go and see a specialist that does that. There are not that many, to be honest, in the UK. And I'm a little bit out of breath, probably not from pleural effusion, but from just having a bit of a fever before. So excuse the long pause I take. So they put this needle, and the needle that you see in the slide is the actual needle that is being used. It's sort of flexible, but not too long. So, and then it basically pierces. It goes through the rib cage. They mark the spots. They use tactile information with their fingers to try to do that, and they put the needle in, and they either aspire, they suck the fluid out actively, or they attach it to a basically bag and then let it drain with gravity. So the issues, of course, here is that there's great variability in skill among the specialists. You don't have a lot of specialists available. There is low confidence, especially because this procedure is pretty blind. There's very limited visual feedback. You could use an ultrasound at the same time to make sure you see where the needle is, but the procedure is so fiddly and needs such both hands and eye coordination that they actually prefer not to use ultrasound in most cases. So they really do it in a blind way. So basically that's why we have a lot of patient risk. So although it's kind of a simple procedure, it's not uncommon that you will have piercing of visceral organs, you have bleeding, infection and complications, and even a collapsed lung if you go as far as that. So, okay, so I'll give you first the motivation as well for prostate, and I'll show you some of our results. So prostate cancer at the same time is a very serious condition. We have new cases that rise annually. For 2025, they rose to 2.9 million. And it is the second cause of cancer in individuals assigned male at birth, which basically we have 12,000 deaths per year. So biopsy, we have a long flexible needle. So this is very similar to the needle in the previous case, but it's much longer this time and made of a little different material, of course. but it has this bevel tip. I'll tell you about it a little bit more in a minute. Again, there's very limited visual information. It's basically, the information is coming from this ultrasound probe that is a transrectal ultrasound probe, and it basically, you can imagine it as having two transducers, one on the top, one at the side, and this is how you see as a clinician two 2D images, one from the top, one from the side, and you're trying at each time to understand where the tip of the needle is. So it's a very difficult thing to do. You have to train for a lot of time. And there's, of course, tissue anisotropy between patients, but also, for the same patient, the prostate and the tissues before that are not uniform. There's very, very different. The prostate, if you are an elderly individual, can have calcification, of course, and then that means that your needle will just hit one of those and then go the wrong way. Now, in brachytherapy, the treatment is where they place radioactive sources inside the prostate gland. They're trying to do this in a very uniform way around the cancer. That's the way they need to know where the cancer is. And if they put seeds too close together, they might damage the tissues more than they should. If they put them too far away, they might not kill the cancer. And it might destroy healthy tissue around it. So this is where we have spacer placement, as I mentioned. So you can see here, if the bottom sort of round thing is the colon, and you see the prostate above, there's about a 2 millimeter gap in between them. And this is where we come with a needle, and we basically want to put this gel, this barrier between them, so that if the cancer is near the back of the prostate, near the colon doesn't get damaged. Now, there are many problems with this procedure as well. If there's no accuracy, the needle could pierce the prostate. It could pierce the colon. Now, none of this is basically life-threatening, as it is right there and then, because this gel can be reabsorbed, but it takes a minimum of 3 months to do so, sometimes 6 months. So that means that for this amount of time, you cannot do the treatment. You cannot go and do brachytherapy because you haven't protected the area. And on top of that, if you have pierced the prostate, that might mean that you have pushed some of the cancer cells out of the prostate, and therefore the cancer cells now are out of the prostate. When you do brachytherapy and you put in the active seeds on the prostate, they're not going to kill the cancer because it's out of it, and it might metastasize. So basically, you understand that all of this is to say that these procedures, they include a lot of human error. I mean, surgeons train for thousands and thousands of hours, but there still is human error because these are such delicate procedures. And this is where we need improving of accuracy and also better training. So all of them are ultrasound guided, as I said, using the transrectal ultrasound probes. So spacer insertion and biopsy have very similar needles. Spacer has a bit of a shorter needle than the biopsy. So both of them at the end have this sort of bevel tip. So you can see bevel tip means basically that is a bit of at an angle. And this is done on purpose because you can use that to steer your needle. So there are two different types of steering the needle. You can basically manipulate the base. So the base is this part here. You basically hold it by hand, and you can move it up and down, left and right. And there is some deviation of the needle inside. But of course, you cannot have a lot of moving because the needle is inside the tissue, right? So there's a pivot point at the perineum of the patient. I don't know if I made it clear. So this is ultrasound probe in the rectal, and then this is the penis and testicles, and then in here the flexible needle. It doesn't actually bend as much as this picture shows, but you can see the needle goes through the perineum just above the rectum. Okay, so you can do these two different types of manipulation. That is the external to the body manipulation. But then what you can also do is you can actually rotate the base and basically reorientate the bevel tip of the needle. So when you're pushing you're pushing forward, the needle basically it goes up because of the non-uniform forces that are happening at the needle tip. Then if you rotate it, now the bevel tip is pointing downwards, so you can actually go down. So basically you could, in theory, have a sort of, curved trajectory, and you could even avoid obstacles such as calcification, as I mentioned before. And you can see on the top right, the two views that you see from the ultrasound. So if you go to the sagittal view, you can sort of see in an easy way, I guess, this is the needle. It's a nice straight to white line. When you are on the sort of front and, this black circle, this semi-disc at the bottom, that's the colon basically. So you can see here the needle, and which can be easily missed by someone who's not a clinician, because it's just another little bright dot into this 2D black and white image. So what we did to tackle this problem is first we looked at modeling the needle. So we used the absolute nodal coordination formulation to describe large needle deformations, arbitrary large rigid body motions, and we look at the forces that were caused using a force torque sensor, and we looked at the visual feedback at the same time using, for that time, we didn't use ultrasound, we used cameras, as if our body was transparent. Of course, that was very, simple lab conditions. Now we have moved on to ultrasound. And we tried then to do real-time simulation of these. You can see, sorry, I thought that was playing. You can see how basically you can expect this needle to move when you go up and down and left to right. So this is for the external manipulations. So once we did that, we modeled the tissue, and then we modeled the interaction of the two. We set up a system in the lab consisting of the two cameras you see here, camera 1, camera 2, one from the top, one on the side, simulating the conditions. So you have an ultrasound in a way, and then we used one of the robot arms to basically do automated insertion of the needle. So here you can see it was a shrunk robot arm, and at the end of it, it had a force torque sensor and the needle attached to it. So this, first of all, was to verify the motion of the needle and verify the model. So this was quite successful. We confirmed it against the model, we confirmed it with experimental results, and as well as a sort of commercial model that was available, which I think it was ANSYS at the time, but actually the absolute nodal coordinate formulation model was better than that. So that meant that we had a really good model that could be used real time, because ANSYS cannot be used real time because it's, part of a bigger package. So then we looked at modeling the tissue. Now you tell me that, you can't really model any tissue. You can't, because patients are, as I said, different to each other. So we started, of course, with modeling the nodal points, and we used the XPBD, the extended position-based dynamics, for this one. And then it really had to do with how we actually did the control to try to overcome the fact that patients are different to each other. So we, I'll tell you about this in a minute. So we used a very simple simulant in the lab. It was made out of ballistic gelatin, the same recipe that FBI is using, but to simulate the different layers, not to be perfectly accurate to the human anatomy, but just to simulate the different layers and how the needle could deform between different layers. We made different consistencies of this gelatin simulants, and then we cut them in pieces and we put them next to each other to create a non-uniform sort of piece of phantom. We also added a motor at the end of the robot arm to simplify the motion of the arm. So the robot arm will basically be controlling the up and down and left and right, sort of the outside of the body movements, of the simulant movements, and then the motor that was just attached to the base of the needle was to simulate just the axial rotation that would only change the orientation of the bevel tip. So here you can see the architecture again. As I said, we had the cameras. There was a user interface, the motor, the robot arm, the force-torque sensor, and there was model predictive control because of the model we had created, and we used adaptive control, and that was the key to this because the whole system basically was learning in a way and adapting to the tissue that you would give it. So we didn't go as far as testing it into, silicone simulants or animal tissue, or even in simulants with chalk. This is the next step that we probably will do in the next year, hopefully. But the theory that we have, the hypothesis, is that the adaptive control could actually tackle this as well, these challenges. So you can see here on the left, the manual needle insertion, and on the right, you'll see the autonomous needle insertion. So for the manual, there we had a few different naive users from the lab holding the base of the needle with an April tag to try to track how they were manipulating, to try to get as many human factor data as we could, also to try to understand the behaviors of they were using. We had sort of two groups. One group that we said, this is the insertion point and this is the target point, and then we would show them the straight line path, sort of the path of the least distance between the 2 points, and we say, no, this is what you want to try to follow. And they would see the two different views, and they would try to follow. So if you just focus on the left two images, up and down to start with, you can see that the person probably doing this experiment was focusing more on the bottom image because they're doing quite a good job in following the line from the above. But when you actually look at the top image, they have actually missed the target by more than 5 millimeters. And if you're doing prostate biopsy, you want to try to focus on different quadrants, and you want to get sample from the right area. If you miss the area, then you haven't actually done your diagnosis properly. Now on the right side is as I said, the autonomous one, and basically the robot could always hit the target with a maximum error of 2 millimeters. Part of it was due to shadows of the camera. I think we're hoping that when we move this to ultrasound with the same techniques, the error would be even less than 2 millimeters. But according to clinicians, 2 millimeters was actually good enough. And that was the maximum. It wasn't even the mean. The other thing that, I said this was with naive users, the manual study, but we did try it with surgeons as well. But we didn't include it in our research results because we didn't think it was valid enough. The system that we had created was a good simulant for the procedure, but it wasn't exactly what the surgeons had actually used and trained on. So the results wouldn't be representative of what perhaps they are doing. So it would be a very difficult case to then try to argue that, But anyway, as a sort of anecdotal results, we tried it with 3 different surgeons, and they all had way worse error than 5 millimeters. And the smallest errors was usually from people in the lab who were really good at playing video games, as usual. So the manual insertion study we did quite extensive, and we wanted for this to really understand the different behaviors that they were using and sort of what strategies were they're using to try to get to the point, to the target point. So as I said here, they will usually look at one of the trajectory of the 2 images, and they will probably be very off in the other sort of 2D plane, as you saw in the video. We also try to look into qualitative data. How about, what happened with it? Was it demanding, the task? What they think? Was it mentally demanding? Was it physical demanding? What does it have to do with the cognitive load? Was it hard to succeed? So what did they think about the axial rotation and the motor? Sorry, there was no motor. What did they think of the axial rotation? Did they use axial rotation more than the outside rotation? It was quite interesting. This was picked up by the engineer and a few other media at the time, as it will refine the future of surgical simulation and biopsy. I mean, it was really good results, and I think there's a lot of work to be done in this still. But we were really excited about the results of this project. So we actually have done this part, the future direction of exploring of a semi-autonomous system, where we still are doing manual insertion. And now, instead of having the whole robot, we have a surgeon holding the base, but we give the surgeon an extra motor to just do the fine sort of orientation of the axial rotation. And we just did this with a master student over last summer, and the results were quite good. We want to, of course, look into having a simulant that might have shock inside to simulate calcification and see if we can actually do some obstacle avoidance. We want to look at training and how we can use this to create a simulator to improve accuracy for new surgeons, and therefore haptics. Add a haptic robot to help them actually do this now, instead of using phantoms, but using a virtual environment and a virtual haptics engine. And the replacement of cameras with ultrasound is still ongoing work now. So for brachytherapy, we wanted to use similar techniques, but we found out that there's a key difference here. That is the tip of the needle is not bevel anymore, it's actually uniform. So a lot of the methods that we were using in biopsy don't really apply here in the end, but we still can use robots to manipulate externally. So the manipulation here is the up and down and left and right instead. And the difference also here is that there's not one needle, it's actually multiple needles at the same time. And for this, we used a dual system. This was something that was happening up to the end of 2024. Beginning of 2025, and we had a linear ultrasound at the top, which of course wouldn't be the actual case, because these procedures needed transrectal ultrasound to make sure that you can actually view the needles. So we have multiple needles, and the idea is, again, you can see it going into the medium. When you're using silicon simulants, what's interesting here is that the needle leaves a path, a pierced path in the silicon, and after a few uses you have to throw it away, and then you have to create a new one. So that's a challenge that we're still trying to overcome. And this is now the current system. Well, it's not the current system, it's the last to current, the second to last system. We have you can see here the ultrasound probe being held by one of the robots. You can see the scanner at the back. And you can see now the needle being held by the second robot. And you can see on the right here, one of the destroyed now simulants. This was a commercial simulant that cost about £1,000, a little bit more actually. And honestly, it was good for 4 hours. Then we had to throw it away because there were so many needle paths in it that you couldn't really see anything anymore in the ultrasound. So now, and that is one of the novel things that we're doing in my group, is we're creating our own simulants, and Joe Luca is working on this quite a lot, along with some master students that I had in the previous summer. And we're making them out of different sort of biodegradable materials, such as gelatin, agar, and so on. We're playing with different consistencies of them, And the idea also that we're exploring in a different project that we're waiting to hear from EPSRC is whether we can then use this to expand medical education in low-income countries. So we've got partners in Canada and Senegal to work into this. So hopefully more on this next year. So I promised to talk a little bit about more on the sort of the haptics and the tactile stuff that we do. So we had as motivation on this the breast cancer, and we tried. The idea was to create a platform that you could go and examine your breast autonomously without necessary presence of a specialist. Again, starting from the motivation, there is self-examination that we do. Not many people do that, unfortunately, because also they don't feel very confident on it. Then sometimes they discover something and they go to the GP to have a consultation. The GP will usually do a digital palpation. They often say that they're not certain, they don't want to say you're fine and then send the patient away in case there is something. So there's something that we call over-referral. Then they go for imaging with a specialist, ultrasound or a mammogram, and this is something that's very uncomfortable. You can see here, it's basically you put the breast between these two plates, and it's kind of brutal. Patients in our groups later that we had mentioned that they felt like a piece of meat. They hated this. They felt that so it would be preferable to them to have a robot do this than a person treating them as someone who's not a human. And the other thing is that for these examinations, you're not really called often. You have to be over the age of 50 to be called a thing, unless you have a history. And also during COVID, this screening really fell down. And I think there was a campaign from Cancer UK to try to increase screening again. So the idea we have on this was to try to use some of our tactile sensors in combination with robots to try to create a platform to do this automatically. So we started with, this started during COVID, 2019. It's been quite a few years now, and the project has been on hold for the last probably 2 years due to lack of funding, but we still haven't given up on it. So we started with questionnaires to try to see acceptability and whether people would like a robot touching the breast, something so intimate. And as I said, it was actually quite interesting that they were very, open to it. And then we actually did some more robotics research and technological research about designing sensors and robot devices to hold the sensors. And all the while we had 12 patients. Well, they're not patients. Some of them were previous patients, but we would consider them public contributors that were giving us feedback in the research. So in the survey, we had 155 participants. 98% said that they would definitely use that, or definitely use such a device. They were very high level support, as I mentioned. They praised the potential for the accessibility, putting the system somewhere such as pharmacy, at mobile clinics, at in a shopping center, so that you can just go in, read your book, 15-20 minutes, or look at your smartphone for 20 minutes while you're doing your shopping. And they were hoping that this would actually increase accuracy, but they were also worrying about how would you integrate it into the existing structure? How would you then look at the data? Who gets your data? Do you get your data? Do you get the result? And you start to worry, before the GP sees it. And a lot of these were not explored in our project, but hopefully in the future. So as I said, we had 4 focus group meetings spread throughout the duration. Again, some of this, well, a lot of it was during COVID, and we couldn't get the people to interact with what we were making. So we ended up making mock-up designs and sending them to their houses, which I thought it was really good. And we got really interesting feedback that actually did help us with research, despite having to do this online. So more from the survey, 7% wanted the device to be soft and comfortable. And we thought that was interesting because we never told them that any of what we were making was going to be soft. But this was unprompted completely. 1 out of 155 preferred it to be hard. And most of them didn't mind either way, as long as it just basically worked how it was supposed to. When we actually showed the device to the participants, some of them were worried that it was a bit sticky, and soft, yes, but sticky. And then that maybe started us thinking about what sort of more technological tests we could do. So therefore, we had the sensors that I'll show you now in the next slide, and then maybe we should not just test them against the surface, but then also put mediums, put talc, put lubricant, sort of the similar sort of materials that they use in a hospital, such to lubricate when you're examining something. So this shows you the concept. So it was a project between Imperial College, UOB, and Lincoln University. And the idea would be to have this mobile booth that you can go in, that you're in it privately, and you have a box that has a robot inside and the tactile sensor. You sit in a actually comfortable kneeling chair. These chairs are meant to be comfortable. Everybody thinks, oh, this looks really uncomfortable position, but they're sold for the ergonomics. And you can see part of the device that you'll see in more detail in a minute, basically palpating the breast in different configurations. Then you finish, you go out, you click, you can send the data to your email or to your GP. Again, as I said, not explore at the moment for this. But these are some of the sensors, okay? So we started with a concept that you see on the left. So this was work before the project. And the idea, and this is what inspired, in a way, the soft tactile sensors that we made. We had this sort of pillow, like inflatable little pillow that we squeezed the finger. And by this squeezing of the finger and the inflation, deflation of this pillow, you would basically get different sensations on your finger. And therefore, we use that as a sort of a teleoperation game to try to figure out for the users which of these red balls would be harder or bigger. So using this concept, then we created these 2 tactile sensors, one called Espresso in the middle, and then one called New Tip. So Espresso was fluidic and New Tip was pneumatic. So Espresso basically worked by having this membrane here that you can see in the middle and bottom. Inside, it would have a bit of a gap of air, and then there would be a number of tubes coming out from the other side that would then be connected to fluid. So each tube had water inside it that would then dye black. And then a camera would monitor that the fluid going back and forth as you would press on the membrane. The same concept here was on the New Tip sensor, but this time the camera was inside the membrane and would look at these white dots basically deforming. So this was inspired by an older sensor that they had made by Jonathan Roster, his PhD student, in the lab in many years ago, 2011 or before. It's called tactile. But what we did different here is that we made it inflatable. A tactile usually had gel and it was deformable, but it wasn't inflating. It was a standard stiffness of the membrane. We made this inflatable, and the same was true for the Espresso. Now, in the same way as this fingertip haptic device on the left was inflatable and deflatable, and inspired this too, by inflating the membrane, what we basically had in the end was a sensor that we could tune its range and its sensitivity. So when we wanted to palpate something on the surface, we could have it nice and soft, and just figure out the difference on the surface. When we wanted to palpate deep inside the tissue, such as a tumor that is near the armpit or near the deeper layers, so the muscle layers or the breast muscle layers, then we could inflate it, make it stiffer, and push harder. So that basically gave us more of an option on what we could do with the sensors. I'm trying to change the slide. So you can see here the espresso sensor, how it's basically working on a robot, attached to a robot. And you can see how the tubes are filled with this black water. And here you can, in the middle, you can see how they move back and forth when it's touching a surface. And you can have a camera looking at it. You can do some basic open source image thresholding, and you can figure out where it's coming from. We could, in the previous slide, here we can actually palpate different shapes that were really, really small, even as small as 0.6 millimeters, and we could, with quite high accuracy, replicate it, even when it was a regular shape, like this sort of hexagon, that's more of a pyramid hexagon. And you can see here there was this sort of ball, like a, what you call them, this hard ball that we just bounce around, and we hit that inside a thick layer of tissue, of silicone tissue, and you could still sort of try to see where it was. And the novelty for this is that we could go in deeper layers than usual other tactile sensors can. So that was a novelty, really. So we started by a grid of 3 by 3, 9 sort of points, and then we moved it to a more hexagonal beehive shape that you can see on the bottom right. And initially, the one you can see in this slide was about 20 millimeter diameter, but we have actually now miniaturized it to a 6 millimeter diameter, and that was I haven't included it here, but it was basically part of a project Braille pen where we actually use it now to read Braille on the tip of a pen. So I showed you the sensors, but what is it actually that's holding the sensors? And we made 2 different types of robot holders. We started with these, the Lotus, and which is sort of a more inspired by an organic flower and has compliant sort of opening petals, but you can see obviously from the initial drawings to reality, it looks quite different. And the idea would be that it's attached to a robot. The robot outside manipulates and rotates, and then there's extra motors that are simply opening it and closing it. The 3 sort of finger-like digits of it. The other design was called Iris, that was inspired by the diaphragm of a camera. Both of the designs, the Iris and the Lotus, were very simple. They had only 2 degrees of freedom each, basically the opening and closing and the tilting that you see here of the sensors. Those only 2 degrees of freedom would allow us, though, to cover a breast that was of uniform shape and size. And we also made this a parametric design, which means that the device could have anything between 3 and 8 digits. And I think we sort of compromised with 5 to try to see how quick it would be to cover the entire surface of a breast without being too onerous. So, sorry, just as you can see on the bottom right here, again, some of the tests we did with a phantom that was actually taken from a volunteer in Imperial College. So just a last slide about the public involvement in research. We had these 4 sessions, and this is the artistic sort of representation of the very last discussion, where we really tried to bring the project together, understand what people thought and what we could do in future steps. So there was a lot of information to take forward, actually, but there were a few interesting points I'd like to mention. First of all, most of the contributors were more inclined towards Lotus rather than the Iris, because it looked a little bit more organic and sort of safe and comfortable. but at the same time, they didn't really mind. They said, just hide it. I don't want to see it, you know? And if it doesn't see it, it can be as ugly as you like it and as mechanistic as you like it, as long as it does the job it's meant to do, and as long as it does it better than my GP. So that was a big, an interesting part, at least. The other one was that they really thought that men should be included in that, and I actually did try to do that from the beginning, but there was also this sort of thing about, oh, men are always involved in sort of all the research done for men. This is a women's issue, and let's start with women. In the future, we'll look at men. Anyway, not sure I agree with that, but yeah. So I talked a lot about the data as well. That was a big what's going to happen with that, and that's a big unknown and needs much further exploration. So I think with that, I just give you a very quick whistle-stop tour of some of the stuff we're doing. We're doing a lot more things. So if you're interested, have a coffee with me and chat over the next few weeks or year. And I'll be happy to take any questions you have.
Yeah, thank you.
Thanks for the great talk, Antonia. And now we'll do some questions, or do it online, and then if anyone in person can say the questions, and if anyone puts the questions in the chat, then we can repeat it to you. If that sounds good. Is there a question? Yeah, if you want to go first, Mikkel.
Yeah, just let me. Well, everything was great. Thank you for the great presentation. On this last one, in which you are creating a tactile robot, is there any reason why there are no other type of sensors that could be added, like ultrasound or something like that? Is it because tactile is so good?
No, it's a really good question. So we started the project during a sandpit. That's why I'm so always doing sandpits in our school. A sandpit organized by EPSRC and Cancer UK, right? So they just basically throw us in the same room for 3 days, and we came up with a project. And the idea was that tactile sensing is not enough, exactly as you said. We need to combine it with another modality. So this was only first step of the project, to look at tactile information. And the idea is that in future we will integrate it with ultrasound. And this is important, as you might probably from digital health know, triple assessment is what you need. You need 3 types of assessment for example, so digital palpation, ultrasound, mammogram, and so on. So definitely we will look into ultrasound integration of that.
Yeah, thank you.
If I can say a question. So I think the Artemis project, you're kind of automating breast cancer detection, right? Would there be this is sort of a side sort of thing? Would it be possible to do the same thing for, let's say, testicular cancer? Since I'm a guy, so that'll be what I'm interested in.
Well, okay. So let me start by saying, detecting cancer is probably not the idea for this Artemis project. It was more about maintaining breast health, try to catch something as early as possible, having data, because when you do screening now, you could do screening every 3 years. But the idea of when you're automating something like that is that you can do this examination every 6 months. And when there's a slight change, you can immediately catch it because you're comparing your own data. So that said, there's no reason why it wouldn't work for another area of the body. Of course, the device probably would have to be smaller or something like that. But yeah, why not?
Okay.
but men, to my surprise, actually do get breast cancer more than I thought.
Okay, I did not know that.
And I think this is also it was a motivation, because when you're doing the mammogram, it is most painful for those who have really large breasts or really small breasts, and I think men belong to that second category. There is an online question.
Yeah.
Thanks.
Yeah. I'll read out the question. Would breast screening be able to find lumps that locates in deeper parts of the breast?
Well, that would be the idea. The current method does, hopefully not always, but it does, especially when you have a triple assessment. But the idea with these sensors was this. That was the goal, to try to change the sensitivity of the sensor. So you have one sensor, but you can then look at the surface, but look at deeper layers as well. And I think part of what we did, as I mentioned this before, the novelty here was that we went deeper than most tactile sensors had at the time, which I don't have the number in my head, but it was more than 20 millimeters inside the layers of tissue. I think it was 20 millimeters. Maybe it was more. I can't remember now.
I have another question.
Go on. Okay.
When you were showing the I don't remember the name, but I think a prof that yeah, the prof that was being inserted into the gelatin, and you mentioned that the clinicians were not used to use that gel that you had. I was just wondering, what do they use?
It wasn't the gel itself, so they use humans, right? They put needles in human bodies. But what I meant there, it was that the whole system, we had, they usually, they got the person, usually a man, in this sort of gynecological chairs with legs up on either side, and then they would sit comfortably on a chair with wheels in front of the person, and they would adjust the height as they would like, and they would left hand ultrasound probe, right hand needle. Okay. In our system, the whole robot cage thingy was on top of a table, and they had to stand to be able to reach at the more comfortable sort of position. That's why it wasn't exactly a replica of what they're doing. And that's why we were worried that the validity of the results wouldn't be accepted, because you could argue, well, their error is due to, that's not the system they have used to using, they're used to using. That's what I meant.
Yes, okay. I thought it was because of the medium that you were using. But
I
then
mean,
for
I guess
training,
that's another part, yeah.
But you say actual people, but for training they don't use actual people, probably, no? Or
Well,
I don't know.
So,
Yeah.
I mean, if you look at, so this is where a lot of the phantoms that we make, play part, right? So, if you look at Limbs and Things, one of the biggest companies in Bristol and in the UK that sell materials to train, they use foams, they use silicons. Foams are cheaper than silicons. They use this stuff to do surgery and to do suturing and all of that. And when it comes to the specific procedures for needle insertion, there are commercial phantoms, such as the one from Zeal that we used briefly a year ago. But this costs £1,000, and it's good only for a few insertions. Just it's not worth it. NHS won't be able to buy this. So instead, they use they use the foam stuff. That's what they use, and then when they actually train, they are next to an actual clinician who is more confident, and they maybe try for 2 minutes, and that's it. That's how they train, unless they go abroad, and that's what happens a lot, where they can train on animals and stuff.
Mm-hmm. Yeah, thank you.
Hi, Antonia.
Hi, Matt.
A quick question on, so you said you for the needle insertion, you were working towards going towards like ultrasound as a way of like guidance through like opaque tissue. I just wondered like kind of how that would compare to like a video feed in terms of things like because in terms of like ultrasound contrast and noise and that kind of, especially when it gets quite deep into the body, and how that would kind of affect the accuracy and then the tracking of the needle as it goes in.
Yeah, that is a good question. There's a lot of research on this. So it's a tricky one to answer because the colon is not a tube, like a straight, it is a tube, but it's not a straight tube, right? And a lot of the phantoms that exist, even that really expensive commercial one I mentioned before, has it as tube. The ones we are making now out of silicone and gelatin and all of that actually has a more high fidelity, close to real life anatomy. So you put the transrectal probe in, which is really rigid, and it kind of straightens up the anomalous tube of the rectum. So then the needle is sort of put in parallel to that. So it never is too far away as, you know, you go into like deep inside the body, because they sort of go in together in a way, but you still have to manipulate the probe to be pushing up and down. And very recently, in the last, you know, 3-4 months, we discovered that they're using some funny condoms. They're called basically endocavity balloons, which is basically an inflatable condom that has usually some sort of lubricant inside or air. I think it's lubricant that basically make this contact between the ultrasound probe and the anatomy tighter so that you can have better visibility. And then we thought, why are we even using a second robot? That's why I said that the dual system we were using was the second to last one, because now we're using this a makeshift endocavity balloon, and we don't have to have a second robot anymore. We don't have to do so much manipulation because we're using an inflatable condom instead.
Yeah, it's really interesting. Thanks.
Okay. I'll ask another question if that's all right. I think you said you were controlling the needles using model predictive control and adaptive control. Was the results differ depending on like who you're sticking the needle into, like depending on the shape, the size, etc.?
Well, we for this we use the same needle for all the tests, which was the biopsy medical needle, and then the only thing that we changed was the medium. We took kind of the medium, because we all use gelatin, but we used sort of single block of gelatin or multiple different blocks of different consistency. So we did have a non-uniform simulant, and it still followed with really, really high accuracy the target. But again, it remains to be tested when you add something very different, such as chalk inside, or, you know, silicone or something less easily to pierce.
And more of a like separate question, or like more crazier question. Like you've learned a lot of stuff about like robotic hands and stuff like that. What would you say could any of these learnings be used for like robotic feet, for example, since that's like the analogous things to hands?
Well, God, my useless.
Yeah, sorry, it's a hard question.
But I do know, and I have seen people with sort of hand differences and or impairments, however you want to see it, depending on the level. They use the feet sometimes, and they use them in such sort of dexterous way that is absolutely remarkable and amazing. They can write, they can paint, they can do all sorts of things. So interesting, you know, interesting idea.
Hands for feet.
But
yeah.
in terms of, you know, what I have focused a lot is to sort of try to add sensors to these different gloves that we make, to then try to get all the information from the hand, what is the hand doing, what the fingers are doing, what joints are doing, and then try then to use that really rich sort of data set to whatever else, the surgical instruments or virtual environment, whatever. I guess a lot of the same sensors could be applied for feet, I guess, because why not? It's still a wearable. It's still something that it wouldn't work if it is completely rigid. It has to be soft because it has to be nice and wearable. So,
Okay,
good.
great answer. Any other questions here, or any other questions online? I don't see any other questions online, so I think we can wrap it up there. Thanks for a great talk, Antonia, and I hope you get well soon as well. Okay.
Thank you. Thanks very much,
Okay.
and thanks for the invitation.
Okay. Thanks for joining, everyone. Have a good day.